Now, moving along from specialized thoracic surgery, it gives me great pleasure to invite our international guest speaker, René Peterson. René does not need any introduction, and he's going to talk to us about subspecialist services on national outcomes with Denmark as a model. Thanks, René.
Thank you very much, Three, and thank to the CTS and to Etikon for the privilege for me to come here to share our experience from Denmark in this issue of subspecialist service. I have some disclosures, as you're all aware of. We run clinical immersions and mentorships from Copenhagen in comparison in a partnership with Covidian, and I'm speaker for several companies as well. So when we look over Europe, thoracic surgeons have different backgrounds. In Scandinavia, we're trained in cardiothoracic surgery. In Denmark, at the end of our specialty, you have to choose whether to do cardiac or thoracic. So consultants are split up in either cardiac or thoracic. No one's doing a mixed practice anymore. In Sweden and Norway, there are some geographical challenges. So to be able to be on call, and because there are not so many surgeons in the units, they need to do both. So they still do mixed practice. When we look at especially the southern part of Europe, thoracic surgeons come from a general surgical background and trained thoracic surgeons. Some are separate thoracic units, but some are general surgical units where you have a division of thoracic surgery. When you look at a country like Holland, we've had several visitors from Holland. They have, or had at least a few years ago, 55 units performing thoracic surgery in a population of 18 million. So there's a lot of general surgeons who's doing a few lobectomies. And we've had visitors who wanted to train VATS lobectomy, and when you ask for their volume of lobectomy, they did maybe 10, 12 lobectomies in a year. And, you know, if you believe that a learning curve consists of 50 VATS lobectomies, it's going to take a long time to complete a learning curve, and it really doesn't seem to be worth the bother, does it? So in Denmark, looking 15 years back, we had 12 units as well. Some of them were general surgical units with a very skilled thoracic surgeon or general surgeon trained in thoracic surgery, doing thoracic surgery. But we've managed over these years to come down to 4 units, which we have been in 5-6 years now. We have in Aalborg, in the northern part of the country, University Hospital. It's the smallest unit, but it's a university hospital. We have Skyby in Aarhus, and we have Odense, you know the team very well, and we have the team in Copenhagen. We used to be 2 units in Copenhagen. I'll come back to that. Copenhagen is the biggest unit, the capital, and it's also all 4 are university hospitals. All 4 are subspecialist thoracic surgeons dealing with the patients. So what was the driver for this centralization? What was the driver for the political decision to come from 12 to 4 units to centralize in this way, and even to merge the 2 units in Copenhagen? Well, one of the drivers was a paper in the Danish Medical Bulletin in 2001, looking at esophageal surgery in Denmark in these 3 years. So 26 units were performing esophageal surgery. Remember, we are 5.5 million people. So there were mainly 4 units performing 92% of the esophageal resection, and the remaining 8% were performed in all these units. And one of the units did 3 resections in 1 year, and all 3 died. And after this paper has hit like the media, and it was in the news, the journalists were outside that hospital conflicting or interviewing the CEO of the hospital and asking him why they do esophageal surgery when they have 100% mortality. And this was the beginning of a political process, which was one of the drivers for this centralization. Another very strong paper presented a year after about breast cancer surgery and the rate of breast-sparing breast cancer surgery showed that in a remote island, Bornholm, very nice place to go for a holiday, but it has really big difficulties in attracting competent surgeons. And if you were a patient on this island having a breast cancer, your odds ratio for, or your probability for a mastectomy was 100% over several years. So this was really, and you know, the breast cancer is something that's very strong in the media. There's been a lot. There's a lot of feelings about that. So this were really the driver for centralization in Denmark. I think that's where it started, and this is the main driver. So administrators have realized that centralizing, shutting down hospitals and merging units, you will save money, for sure you will. So one of the first political process really was how to close all of these smaller hospitals. Well, politically, these hospitals were administrated by a lot of counties. We had 28 counties. And all the politicians in these counties were, you know, the hospital were the main, where most patients were employed in that area. So they were very sensitive to, if they closed the hospital, they probably wouldn't get elected at the next election. So so to overcome this, hospital administration was centralized in 5 units in the country, being further away from the small hospitals, and then each unit may have 5 to 10 hospitals in their area, so they could close some hospitals and still be elected next time for election. So this was really one of the drivers. So to close these small hospitals down and to make super hospitals. And right now we are building 5 super hospitals in Denmark, and it's really promising, I think. So this financial part is the main driver for centralization, I think. And then looking at the poor cancer data, as shown nicely by Mick previously, we've had the same discussion in Denmark looking at Sweden, which has really good cancer survival data. So this was a political decision to make a waiting list guarantee for evaluation and treatment of life-threatening diseases that among cancer surgeons. So it was decided that 28 days was the limit for workup and 14 days for surgery. So after referral, we have 14 days to operate the patients. And so patients, so the Danish Prime Minister said in the television that now we will treat cancer as an acute disease and we'll have a 14-day waiting list guarantee. And so, of course, we couldn't live up to these guarantees in the beginning. And patient came after 16 days, says, so what can I do with my guarantee? Couldn't really do anything, you know. But we try, but we still have problems keeping up with these 14 days guarantee. But it's definitely made things a lot better. There was some recommendation for unit size, recommendations saying from the National Health Board that cancer should be treated in an MDT setting, which killed the few private hospitals doing cancers, because you need to have an MDT setting in the hospital to do cancer surgeries. All cancer surgery are now done in public hospitals. And then money was referred to data registration and national audits and the Danish Lung Cancer Registry, which many of you know, was started 10 years ago, and the National Indicator Project with some indicators for quality of treatment. So when you look at these data from the Danish Lung Cancer Registry over the period from 2003 until 2013, it's a bit